Well, Dr. Felice Gersh, thank you so much for coming on the show. It's great to have you here.
Oh, it's my pleasure. And I'm so thrilled that you're so interested in these topics that we were just chatting about.
Well, we are. Well, yes, producer Eloise and I, we geek out about all sorts of health stuff. And we came across your work and thought, what better person to dive into all things female hormones and polycystic ovaries and so much more. I thought a good place to start was actually, how did you get into functional medicine and helping females? Because I think it would help give the listener a bit of context about your background as well.
Well, the reason I personally got trained in it was that I gave up doing obstetrics. After 25 years and delivering thousands of babies, it was my time to just call it in and say, okay, I want to move on because I have to get some sleep at night. And when I left doing obstetrics, I had this big void in my career, in my life. And all I had left was gynecology. And I did a lot of surgery and I was really good at it. But that was mostly end stage disease. And I thought, can I be more proactive? So I started also asking my pharmaceutical reps when they came through my office. At that point, they were coming through in droves to show me the research that was published that got their drug approved in the first place by the FDA. And when I did that, and I'd never done it before, I found, to my shock, really, how little the pharmaceutical deviated from the placebo in terms of the efficacy. But of course, in terms of side effects, it was tremendously different. I felt really lost. It's like I have these drugs, most of which aren't particularly efficacious, but they sure have a lot of side effects. And I can do surgery, which is very important, but can I be more proactive? So I sort of went on my own little search, taking random courses here and there with naturopaths and chiropractors and functional medicine, but I had no clear directive or path. But then when I was at one conference, I came across Dr. Lodog, and she was the only MD along with me in this whole room full of naturopaths. So I came up to her and I said, Dr. Lodog, I'm really lost. I don't know what to do. I'm trying to get expertise in other areas, but it's very random how I'm like trying to learn this. So she said, why don't you come? Because basically I can see you're qualified to do the fellowship, the 2-year fellowship in integrative medicine at the University of Arizona School of Medicine. So that was in Portland. I flew back home to Southern California. I filled out the application on Sunday night, and 2 weeks later, I was in Tucson, and I did the 2-year fellowship. I completed it in 2012, and I've never looked back, only forward. And then I've taken more directive courses in functional medicine, holistic, and all herbology and things like that to become more expert in what I do. So basically, the way I look at it is I have an expanded therapeutic toolbox. I can do all the conventional, but now I have additional tools that I can use to help my women patients to optimize their health.
It's funny because I think in the field of medicine, you get lots of specialists who they're specialists as opposed to generalists. But often I find that when looking at specifically preventative health, as opposed to treating reactive issues, often people fall into the man with the hammer syndrome, or the person with the hammer. Every problem pretty much looks like a nail, right? And I really enjoyed hearing how you work with Chinese medicine, you've worked with holistic medicine, you've worked with all sorts of different things to add tools to your arsenal, which is makes for a very interesting conversation. So
Well, I do. I look at everything that's out there and I look for science evidence based.
yes, and actually the interesting thing you said about placebos, I came across that in a study of SSRIs as well, where they're not much better than placebos, which I thought was really, really interesting because the world just gets to throw pharmaceuticals at you when actually a sugar pill would be just as good.
That's true. And when a new drug comes on the market, they never compare to old existing drugs on the market. It's always against placebo. And apparently it's not very hard to somehow make a statistical significance, against a placebo. You can manipulate the data in such ways, but they never compare to existing drugs that are on the market. And sometimes the ones that are already out are actually better than the new one coming out and safer.
Yeah, I just think it's some weird perverse incentives, right? And I think that whole system needs to break a little bit to be a bit more open-minded to other methods. But that's why we have people like yourself, which is wonderful. So, please, I'd love to start with fertility and sort of there's increasing rates of decline. I guess there's declining rates of fertility, especially the female
Yeah.
side, and the male. The male is sort of, there's lots of theories about the testosterone and why that's happening. But for the females, my understanding is polycystic ovary syndrome is on the rise. Can you tell us first what is polycystic ovary syndrome, and then is it on the rise? And if so, how come?
Well, it's a defined condition based on medical committees, okay? So in order to have that label, you need to meet the following criteria. You would have to have two of the following three. And there's been some debate about this. One is that you have to have irregular menstrual cycles to some degree, okay? They could even be absent, but they cannot be normal. Number two, you would have to have either on ultrasound polycystic ovary findings, which would mean at least 20 tiny little cysts around the rim of the ovary on at least one ovary by definition, or an elevated anti-Mullerian hormone. That's one category. And then the last category is androgen excess, elevated testosterone levels, or manifestations of elevated androgens like facial hair, cystic acne, that type of a problem. And so you need two of the three and of those different criteria. And the reality is that it's exploding in its incidence of PCOS for a variety of reasons. And it is the #1 cause of female infertility and of many other health problems because it affects the entire metabolic systems of the female body. So it's a huge deal. It doesn't get the light of day in many medical circles. And women are often invisible who have PCOS in the sense that it's not a sexy condition. The majority of women, like 80%, will have these symptoms of androgen excess. So that is very unappealing. A woman who has to shave because she has a beard, she has terrible acne, and about 80% are overweight and obese. Of course, the American population is pretty overweight and obese, but even more so with PCOS. So it's not the kind of thing that a lot of people want to focus on, like, let's put this person with PCOS on the cover of our magazine, because it's not like other conditions that people have that just kind of can have really generally attractive women, so it's a self-esteem buster for women, and it's hitting them in the prime time of their life. So we're talking about women like in their 20s who are dealing with all of this. And, it's just horrible, the kind of issues that these women have to deal with. And they got a lot of fat shaming, of course, like it's their fault, when in reality, their metabolic systems are not working properly. And it's really very, very hard for them to lose weight and to deal with all of their manifestations of PCOS. So it's a very sad, very heartbreaking condition. And even when they do get pregnant, well, it has the highest failure rate of women who undergo IVF, in vitro fertilization, the highest failure rate. And when they do get pregnant, they have high rates of miscarriages and of pregnancy complications. So it's just heartbreaking every which way you look at it.
It does sound that, and lots of follow-up questions off the back of that. I think my first is it genetic? And then how does it come about? How does it manifest? And how can people get it?
Well, there is definitely a genetic component. It turns out when you look at families that a woman who has PCOS, there is a 50-50 chance that she'll have a sister or a mother with PCOS. Even if her mother said, I never had PCOS, I don't know what you're talking about. There's a substantially higher rate of the mother who doesn't think she has a problem will develop at some point in her life diabetes. So the mother actually is affected, even though she doesn't realize it, because she has a milder version. And that's because in ancient times, this is what we think, okay? PCOS was actually a survival advantage. So women with the natural version of PCOS, they have a mild defect in their ovarian function, converting ovarian-produced testosterone into ovarian-produced estradiol, the estrogen made by the ovaries. So it's like an assembly line. The ovaries make testosterone. That's the precursor to all estradiol. All estrogens come from androgens, and estradiol, the ovarian estrogen, comes from testosterone. So the ovaries make testosterone, then it moves down the assembly line to a different set of cells in the ovary where it's converted into estradiol through the action of an enzyme called aromatase. In women with PCOS, they have a little defect in the function of aromatase, so they're not quite as adept to convert the testosterone into estradiol. But in ancient times, it was actually an advantage because it was so mild. Those women had a little bit of built-in birth control. They were slightly less fertile, not severe. They would, instead of having 8 babies, maybe they would have 4, which was actually a survival advantage because every time a woman was pregnant, she risked her life. You know, the maternal mortality was really high. And also, every baby was very demanding, took a lot of nutrients from her. And this way, each baby had more attention, had a better survival chance. The woman had less opportunity to die from pregnancy related issues. So it was actually good. Plus, she had just a slightly higher testosterone level, just a little bit, because it's like a little glitch. You make the testosterone, then it gets converted into estradiol. But if it's not converted just perfectly, you have a little extra testosterone, a tiny bit less estradiol, but not enough to make a big difference of any sort. But that little teeny bit of extra testosterone made those women bolder, braver, stronger, more outgoing. They were not going to be pushovers, okay? So they were like the leaders of the tribe. And so it was a survival advantage. But what's happened is that this natural little genetic glitch that made a little bit more testosterone, a little bit less fertility, but nothing major. Now, when we add in the modern lifestyle, the chemical endocrine disruptors, the one that's had the most research is bisphenol A, BPA, but that's not the only one. That's the one that is ubiquitous. It's in everybody. It comes and goes, but it's always there. And it's from hard plastics, can liners, cash register receipts. It's in all the hard plastics that are everywhere. So it's in everybody. And this endocrine disruptor is an endocrine disruptor for estrogen, but also for melatonin, for testosterone. So it means it mucks up the function, the distribution, the utilization, the storage, every kind of thing with all these different hormones. And when you're exposed to it in utero, when you're developing your endocrine system, it leaves a permanent mark because what they found in women with PCOS, that the receptors for estrogen don't work optimally. So they make less estrogen, and then the estrogen they do make now isn't working optimally because the receptors, and every hormone goes into a receptor. There are other ways that they work, but that's like the main one. And so those receptors are less functional. So basically, women nowadays with PCOS, because of their exposures in utero, and they've also shown that the amount of BPA in the mother, the pregnant woman, is much less than in her fetus. This was not known until pretty recently. It actually bioconcentrates in the fetus of all things. So the fetus has much higher levels than the mother, and it's impossible to not have any exposure in this world. And so we're taking what was a very mild issue, genetically built into those women, that was actually a survival advantage. And now we've turned it on its head because now they have a really significant problem in converting the testosterone into estrogen, and the estrogen they have isn't working properly because that mild defect in the conversion has now been magnified. So now we don't know exactly how this is happening, but we think it's due to change in diet, change in microbiome, all the different things in our environment. So the ovaries are now much more inflamed. Everything in the body is getting inflamed, including the ovaries. And the function of the enzyme aromatase is even less functional. So they have even more difficulty converting the testosterone into estradiol. So the brain says, ovaries, please make more estrogen, because they have sensors in the brain. So the brain says, okay, I need more estrogen. I'm going to tell the pituitary to talk to the ovary. The pituitary acts as the intermediary. So the pituitary starts making more luteinizing hormone, LH. That triggers the ovary to make the precursor to the estradiol, testosterone. There's no problem in making testosterone. Testosterone production is a different skill set. So the women with PCOS can readily make testosterone. It's the conversion into estradiol that they have problems with. So they make testosterone, and then the brain says, wait a minute, I still don't have enough estrogen because the conversion isn't working well. So the ovaries keep churning out more and more testosterone, but it's not being properly converted into estradiol. So see, it's really simple. You have too much testosterone, not enough estradiol, and the estradiol that you have isn't working optimally on the receptors. So basically, women with PCOS have an testosterone excess, which is what creates so many problems with hair growth and cystic acne and so on. And when you have too much testosterone, it also affects your gut microbiome and makes it more prone to making more testosterone. So it's like a double whammy.
Right.
And then, in addition, we have problems with the low estradiol levels. And estradiol is critical for metabolic function, like maintaining optimal burning of fat in the mitochondria. You cannot have optimally functioning mitochondria, the little factories in the little organelles, the structures in cells that burn fat and glucose and turn that into energy. And they do all sorts of other things, controlling cellular functions and so on. Mitochondria require estradiol in order to work properly. So women with PCOS cannot properly burn fat and make energy, which is not their fault. So they're tired. It's like living in a sea of energy, but not being able, which is fat storage, okay, but not being able to convert it into practical, usable energy. So it's horrible. So they have all this energy they keep storing, because that's a different skill set. Making fat is a different skill set than burning fat. And so they have dysfunctional mitochondria, so they don't burn fat well. So they're tired, they have low energy, and they have inflammation throughout their bodies and in their ovaries. In fact, they've done studies where they've pulled fluid, follicular fluid, from around the sacs holding the eggs, okay? And they found lots of inflammatory cells. So this is also terrible, obviously, for fertility, to have inflammation affecting the quality of your eggs. The storage units of the eggs are all full of inflammation. So, and inflammation throughout the body, because estradiol is the control for the immune system. It does everything in the body. Estradiol is like the master hormone of functionality in the female. So it controls the immune system. It turns on and off inflammation as you need it. But when you don't have enough estradiol, the estrogen made by the ovary, you go into the default, which is pro-inflammatory. It's like you only have the on switch for inflammation, don't properly manage the off switch. And then compounding that is that we now have data originally that came out of China, where they have a lot of PCOS, a lot in China, that showed that women with PCOS have an abnormal gut microbiome. It's dysbiotic. They have the wrong microbial life forms in their gut, which creates leaky gut, which causes endotoxemia. The contents in the gut, which are toxic, get into the body proper by managing to get through between the cell lining. The junctions are supposed to be really tight, and they drift apart due to inflammation, breaking down the little fibers that hold them together. And that's why they call it endotoxemia. The endotoxins that are in the gut get into the body, creating more inflammation and toxicities, and inflammation in the brain that makes women have depression, anxiety, brain fog. So, in the joints, then they have joint aches. They have inflammation everywhere you go, in the skin. And that contributes to the acne, because the microbiomes that are natural become abnormal, even on the skin. And in the vagina, they have more vaginal infections. They have more mouth dysbiosis. They have more gum recession, gingivitis. So it just goes throughout the whole body, this inflammation.
So,
Yeah.
so okay,
So
if I've heard you
it's
well,
big.
yeah, it seems huge, and I'm trying to get. I've got a couple of questions. Sort of, it seems all of these symptoms or all of these physical effects are downstream of that glitch in the aromatase pathway. The testosterone
Yes.
can't get aromatized freely, and the question around that, just on the mechanism, is for males, we create testosterone in the testes, and then that would get aromatized into estrogen, but we hold the aromatase in our fat cell, is my understanding. Do
Oh,
females?
men have aromatase in many parts of their bodies. In fact, in the brain, men during the reproductive years make 6 to 8 times as much estradiol in their brains as a woman would make in their brains. But if a
uh,
woman has healthy functioning ovaries, she makes plenty of estradiol that gets into her brain. But men make estradiol from testosterone in their arteries and, yes, in their fat. They make it in many places. But
oh, no.
unlike women, it doesn't circulate.
Okay, I see. And so where do females have the aromatase enzyme? Is it specifically just in the ovaries?
Oh, no, it's in all these different places. But so women, that's what keeps women going after menopause, to be honest. But it's not enough. Okay, it's
Mhm.
not zero, but it's not enough. So women have the enzyme aromatase in their connective tissue and their fat tissue. And that's one of the reasons why in postmenopausal women, when they do a mammogram and they say, "Oh, you have very dense breasts." That's a risk factor for breast cancer if you have very dense breasts on a mammogram. The reason for that is that they have inflammation in their breasts, which of course is a problem in postmenopausal women, is that they tend to have inflammation everywhere too. That's what somebody coined that term, inflammaging, inflammation related to aging and loss of hormones and nutrients and so on. So when you have inflammation in the breast, then you trigger. So inflammation triggers aromatase activity. And so the breast itself is making estrogen. And estrogen has many amazing properties when things are right, when it's being managed correctly, not like when you're making it inappropriately in an inflamed postmenopausal breast. And when you have too much estrogen being produced in fat tissue because of inflammation, it triggers growth factors. And so it causes the ductal cells of the breast to grow, and that will show as density on a mammogram. So it's what happens when you have too much inflammation triggering the activation of aromatase locally in breast tissue. So it's poor estrogen gets such a bad rap, because when things are bad, it can be like, it can go down the wrong, like pathway, so to speak. It's getting produced because of inflammation. And the reason that inflammation will trigger estrogen production is, I think, it has to do with survival. Everything has to do with survival. So the time of a woman's life when she doesn't make estrogen, but she needs it, is when she is breastfeeding after she has a baby. So, during that time, she has high prolactin, and she is not going to be making any ovarian hormones, because that's why women will not have their periods often, like for a year or more, if they're breastfeeding continuously after they have a baby. But what if she gets a breast infection? Okay, well, she's not making any estrogen, and estrogen turns on and off the inflammation process. It deals with infections and so on, and trauma. So the breast will make its own local estrogen to support a woman who has a breast infection when she's breastfeeding, because she doesn't make estrogen from her ovaries. But like a lot of things, these same mechanisms that can be life-saving in a certain situation can become harmful when you have a lot of systemic inflammation and breast inflammation in a woman who's older, and then you're triggering the same mechanism of the breast making estrogen, only now it's for no purpose. It's not because you're trying to deal with an infection in the breast that you have to manage an infection that's going to then be stopped and cured, and then the inflammation goes down. This is perpetual inflammation in an aging, inflamed woman. So, the most important thing is to understand mechanisms, and how mechanisms that were for survival get misplaced in situations that often relate to endocrine disruptors or aging and so on, where you're triggering life-saving mechanisms, but in the wrong situation. And now they're not life-saving, they're life-harming.
Oh, it's a minefield. I think, just for the listener, if you're getting lost with the mechanism, I think stick with it, because I think when you become familiar with the terms, the mechanism gets a little easier to understand. On like a slight mechanism question, my research, sex hormone binding globulin, and my research in preparing for this, when people have polycystic ovaries, they have chronically low SHGB, sex hormone binding globulin, if I'm correct in saying that. Why is that? Is that because of the heightened androgens, or why do they have low SHGB? And does any intervention to try and raise SHGB help with the symptoms of polycystic ovaries?
So you are right. So estradiol, or any estrogen, will raise sex hormone binding globulin that's produced by the liver, and testosterone will lower it. And inflammation, which women have with PCOS, significant total body inflammation, will also lower it by creating insulin resistance. So insulin resistance is also a standard, unfortunately, a standard finding in women with PCOS. So they're pretty much pre-diabetic at a very, very high rate. And they, for example, will develop diabetes like 7 times more probable than a woman who doesn't have PCOS.
As a result
So,
of PCOS.
right, because it creates this inflammation that triggers insulin resistance. Okay, so, and inflammation and insulin resistance will also lower sex hormone binding globulin. That's where, which is not my favorite, but I have to give credit where credit is due, birth control pills that have estradiol in them, but not real estradiol, ethinyl estradiol. So it's not the same estrogen that the ovaries make. It's a different molecular composition, but it will affect the liver and cause the liver to make more sex hormone binding globulin. So any form of estrogen that's given exogenously, that's given as a pharmaceutical into the body, will raise sex hormone binding globulin. So if you can lower testosterone and raise estrogen, you will then raise sex hormone binding globulin. Now, one way that you can do it without putting women on birth control pills, and the reason birth control pills are really not ideal, is that they also cause an altered gut microbiome. which is already problematic in women with PCOS. So we don't really want to make it worse. And then also women with PCOS, because they're so systemically inflamed, have higher rates of blood clotting, because inflammation, the process of inflammation, includes activation of platelets. So it's, once again, it's a life-saving mechanism in case you're traumatized and you're lacerated and you're bleeding, so you don't bleed to death. You're going to have certain mechanisms come into play when inflammation is triggered, appropriately. So part of that appropriate inflammatory response is to activate platelets so that if you get lacerated, you won't bleed to death, hopefully. And if it's an infection, you'll wall off the infection, because platelets also create like walls. So you can get like an abscess cavity as opposed to having infection throughout the body, and then you get septic and then you die of septic shock. So once again, a life-saving mechanism when it's put in play, appropriately. So the problem is when, things are not, not in the right situation. So basically, we want to try to have everything more back to normal. So if we can try to avoid birth control pills, we would be better off. Also, because of this increased clotting that's innate in women with PCOS, if you then throw birth control pills into the mix, they have an even higher risk of getting blood clot. And that's been published data. So it's not that, fortunately, younger women have low incidence anyway, but this is published data that if you give a woman with PCOS birth control pills, you will increase her risk above her baseline significantly and above the baseline of women who just go on birth control pills. Almost everyone knows that birth control pills do increase blood clots that are, potentially life-threatening. That they have a much higher rate of these potentially life-threatening blood clots that can go to your lungs, pulmonary emboli. So I really don't like the idea. We know that women who are obese, and most women with PCOS, sad to say, are obese, that they're not the best candidates for birth control pills, and yet they're putting them on them. Most of the gynecologists are putting all the women with PCOS on birth control pills. And I don't think that's really appropriate because of the effect on the gut microbiome, the effect on inflammation, the effect on blood clotting, and that also you're kicking the can down the road. You're not doing anything to heal the ovaries. You're just putting them out of commission. And, you are doing some good. You're increasing sex hormone binding globulin, and that will bind up testosterone. You'll also put the ovaries out of commission. And so the ovaries will not make so much testosterone at all because they're like suppressed now by the birth control pill. So you can have some clinical benefits in terms of improved acne, sometimes, reduced growth of facial hair, because you're lowering testosterone. So there are some benefits of birth control, but I do think that there are better ways to address this and long-term to help the woman to heal and be healthier. And that is not done. That's not the common practice, but I do it because I give bioidentical hormones. Obviously that isn't birth control. We're actually potentially making them more fertile, but then we have to consider, birth control if they need it. But some other form, like maybe condoms, something that's not going to be dangerous.
So
But
could you
I
tell
think,
with
giving women hormones is a good thing because then natural bioidentical estradiol will also increase sex hormone binding globulin.
okay, that's a really interesting point. I think I think a lot of people who listen to this would because in the UK specifically, I'm not sure what it's like in America, it's very normal for a lot of young ladies to just go on the pill, and that could be for
Oh,
contraception. It could also
yeah.
be for, as you mentioned, skin issues, and just I don't want to deal with it. I know this helps. Um, when it comes to diagnosing and finding out if you have polycystic ovaries, A, how do you know? And then B, does do young ladies going on the pill, could that mask any symptoms of polycystic ovaries so much so that you actually could go a few years without finding it because it seems to mask the symptoms, perhaps?
Well, this is my personal theory. Right now in the US, and this could be in the UK, it's considered appropriate to start a young girl on birth control pills once she is out 12 months from her first period. That's it. So, and girls are getting periods pretty early. So if a girl gets a period at 11, she could start on birth control pills when she's 12, or just gets a period at 12, she can start at age 13. That's all that's mandated, is that you wait. I've seen women who went on put on birth control pills, and they maybe had their period only 6 months before they got put on birth control pills, but it's supposed to be 12 months. But these are very, very young girls that are put on birth control pills, and often they're on them for 20 years. I mean, it's, because they're put on them when they're 13, maybe 14, and then they're into their early 30s, and now they want to have a kid, and now they get off of them, and they are exploding with PCOS symptoms. And they're told, oh, this was masking your PCOS. And some of them may have had irregular cycles, but they were like 13, 14. That's too early. You can't diagnose PCOS at that age. You could have suspicions, but you can't make an official diagnosis. You can only say trending or it looks like. But so who knows what would have happened if they hadn't been put on the pill. But they're going off the pill and then they're exploding with PCOS presentation. And I think that the birth control pills actually promote the development of PCOS when women are when they're put on them at a very young age and they're on them for a long time. This is my own theory. I want to make sure that that's clear, but I'm seeing this all the time in my practice. So what do I think is happening? I think that when you start women so young, they're still not fully formed. Their receptors are still developing. Everything is still developing. When you're 13, 14, you're not fully cooked. You're still being formed. We know that for a fact. And so you're starting women on chemical endocrine disruptors. Essentially, birth control pills are endocrine disruptors. They're designed to disrupt normal ovarian function. And officially, the contents are actually endocrine disruptors. So you're putting them on these chemicals that are not physiologic hormones that the body would make. They're different. And the body is still developing. And so you're altering the way that these receptors are working, and you're doing something to the ovaries, because the ovaries they were in like practice mode when they were started on the birth control pills. So they hadn't really fully developed their capability of using their aromatase to convert the testosterone into estradiol. And then now, after so many years of being on the pill, you go off and the ovaries are not working properly and the receptors are not working properly. So you're kind of creating the same scenario that women who naturally get PCOS, you're creating it artificially by giving them endocrine disruptors for all those years. And then their ovaries aren't working right. They never really had a chance to get their act together and learn how to make estrogen properly. And the receptors were still kind of getting into the act. And so when you take them off, it's not working right. Now, for some, they snap back and they work fine. But for a very significant percentage, they develop what to all appearances is PCOS. It's exactly the same as women who naturally develop PCOS. But I really believe that it's birth control pill induced PCOS. But, I definitely have to get more research on this, but I'm seeing this like tremendously in my practice of young women started super early on the pill, being on it for a long time, going off, and then suddenly having PCOS for no obvious reason other than they'd been on the pill for all those years.
Well, I imagine if your theory if it's right, coupled with the modern day environment, it becomes this sort of Lollapalooza effect in the negative, right? So you've got 1 + 2, and the odds of that manifesting might increase quite significantly. Okay, so that's polycystic ovaries. That's how it manifests. That's the symptoms. That's who's prone, and all these different things with regards to the pill and the environment. What can we do? Or actually, put better, what is the consensus opinion of how we treat polycystic ovaries, and what are your thoughts about the best way to treat it and maybe live with it?
Well, I would say the mainstream medical community, their way of treating it is to put the women, like we mentioned, on birth control pills. And then along with birth control pills, metformin, which is an insulin sensitizer. So metformin and birth control pills, plus or minus spironolactone, which is sort of blocks, androgen, like testosterone production to some degree, and the receptor function. So from a symptomatic point of view, I can't really criticize that because it can help with skin and acne, sometimes, facial hair, but it's not getting to the root cause. If you believe in root cause medicine, it's totally symptom based. And of course, I'm definitely interested in helping to reduce symptoms that can be so life altering. But I also want to get to the root cause and try to help the woman to be healthier too. So, but that is the standard of care. And metformin has been like mediocre. I mean, if it really caused tremendous weight loss, and you wouldn't have all those obese women on birth control pills and spironolactone and metformin. So it's, mediocre in its efficacious, effect. And now it's add to it for the obesity, the GLP-1 agonists like Ozempic and tirapazide. So that's where it's at right now, is to add for those women to put them on that. The problem with those drugs is that you're supposed to get off of them. Now that could change, but right now, 3 months before you want to try to get pregnant. And during those 3 months, if you go off of it, you're going to gain most of the weight back. At least statistically, that's the way it seems to go. And also, there's no clear-cut exit strategy at this time. So if you started on those drugs and you're, say, like 22, you're going to be on them for the rest of your life. So that's a long haul. And in the US, those drugs are incredibly costly. Sometimes they're covered by insurance, sometimes not. But if you have to pay out of pocket, it's like $1,000 a month for life. Who knows? Because not a lot of the women are not covered for insurance because they don't have full-blown diabetes. They have obesity and may have insulin resistance, but the insurance coverage in the US won't cover that. Okay. You have to have full-blown diabetes for it to be covered. And then also you have to fail on other drugs.
Right. Again, I know metformin is a drug typically used for diabetes, right? And
right.
not
And that's but they use it for PCOS, for insulin resistance.
Right.
And
Okay.
and metformin is a cheap drug, so that's covered by insurance, but
Right.
not Wegovy, Ozempic,
Yes.
and
Those drugs are pretty scary.
Mounjaro, and Zepbound and all that. And they're not covered
No.
unless you have full-blown diabetes in most cases. So that's the standard approach to the treatment of PCOS. Now, and it works somewhat, okay? But if you go off the drugs, then obviously everything just kind of springs back and then some, right? Because, you can have even worse case scenario when you go off the birth control pills, and then suddenly things are even more awry than they were when you started on them. But they can suppress a lot of symptoms, but they do have some additional risks like blood clots and so on. Now, another way that you can address it, and this takes a lot of effort on the part of the patient, of the woman with PCOS, is intensive lifestyle medicine. And you can do a lot through a lot of exercise, having a plant-based, high-fiber diet that nurtures the gut microbiome to try to restore a healthy gut lining, repair leaky gut, get the right microbial population, reduce inflammation. So work on increasing the ability of the liver to detox. Many of the women with PCOS have what is now called metabolic steatosis, but the former name was non-alcoholic fatty liver disease. And so they do not have the healthiest livers. So we know that there's right now no official drug. Maybe the GLP-1 agonists, they seem to do something for everything, as it turns out, but maybe they will help with that. But we know that you can increase GLP-1 spontaneously, naturally, by eating resistant starch, a high fiber diet, by also adding in bioidentical estradiol. Estradiol works in a synergy with GLP-1, and that's published data too. So I give my patients with PCOS bioidentical hormones. They are more like perimenopause in that they still have hormones, but they don't have enough. Okay. And that the trend is getting more towards, not universally accepted, that we should treat menopause as a hormonal deficiency state and perimenopause as a hormonal insufficiency state. And if you think of PCOS, it really is like a hormonal insufficiency state when it comes to estradiol and progesterone, and of course a surplus when it comes to testosterone. So whatever we can do to lower testosterone, increase progesterone, increase estradiol, we want to do, and we can do a lot of that naturally by improving the gut microbiome, by improving fitness, working on sleep, checking for sleep apnea, working on stress, doing mind-body practices. There's so much we can do to improve the overall health status of women with PCOS that's non-pharmaceutical based. And by adding in bioidentical hormones, we can have a lot of the same benefit as with birth control pills, but we're doing it with human bioidentical hormones, which are health giving. They don't have the same side effect profile as the endocrine disruptors that are found in hormonal contraceptives. But once again, if you need a contraceptive, we have to provide that in a separate manner because we are helping our patients to become more fertile. And fertility is a vital sign of health. And that's what's so horrible about the fertility crisis of infertility escalating, because it's not just about making babies, it's about the health of our population, because infertility in a reproductive age person means that person isn't healthy. I mean, they go together, fertility and health. In fact, ancient populations of people, ancient civilizations had fertility gods because they knew how important fertility was, and it was the source of life itself. And so anything that we can do to support fertility is supporting the health of those individuals. And so birth control pills, of course, are the antithesis of supporting fertility. So, it's suppression of symptoms. Like I said, I give credit where credit is due. But my goal is fertility support, so fertility optimization, and overall health optimization. Those go together. And hopefully suppression of symptoms. And I see that all the time. And also women feel so much like so their esteem goes way up when they take charge of their health. They're not just getting drugs, that they're actually getting out there and exercising, and they are working on mind-body medicine. They're learning meditation or guided imagery. They're doing whatever it takes, and they feel in control. There's one thing about women with PCOS in general: they feel out of control. Everything is happening to them, and they can't control anything in their lives. So giving them back some measure of control over their destiny is really critically important. People they have a victimization feeling, like, why is all this happening to me? Well, there are ways that we can take charge. We can't make it all go away, but what we can do is dramatically improve the situation. So we're controlling the PCOS. We're not really curing it. Although sometimes you can't even tell the person had PCOS by the time they're fertile and they've lost a lot of weight and everything is improved. They really don't seem to be PCOS anymore. So maybe we're actually curing it, but at least I would say we're putting it in remission.
Oh, wonderful. Well, I'm so pleased we spent time on the mechanism, because it was a bit of a penny drop moment when you suddenly explained menopause as a hormone deficiency state and perimenopause as a hormone insufficiency state, and then likened that to polycystic ovaries, where the pill would, I guess, in part, sort of mock or be like an estrogen mimic, perhaps. I'm probably using the wrong terminology, but bioidentical
Yeah.
estrogen is way more effective and with way less side effects. One question is, what is bioidentical estrogen? is it? Am I understanding that it's not the synthetic estrogen? What is that?
Well, it is identical molecular composition wise to what the ovaries make. So it's identical. Like when you put it in the body, you can't tell it apart. It's like a total, absolute, identical clone. And I have to, my hat's off to the brilliant scientists who figured out how to make bioidentical. I like to say human bioidentical because it's really the human being that has estradiol. And bioidentical could be some other biological life form, right? I'm talking about humans. So it's identical to the estradiol that the ovaries make. Now we can give that. Now, the reason that they use, for example, a fake estrogen that would never be in the human body, ethinyl estradiol, and they use fake mimics of progesterone. They're not even real progesterone at all. They're completely different compounds, but they can bind to progesterone receptors, they can bind to estrogen receptors, but they're different, is because of the half-life. Okay, like if you had a birth control pill that was human hormones, okay, they're identical to the human hormones, you would have to be dosing it multiple times, because it would not, you you couldn't have it last like one pill every 24 hours. It wouldn't, the half-life is too short. So they had to create these fake ones to put them into birth control pills. But if we're not giving contraceptives, we're trying to give hormones. Why would we not give bioidentical hormones? That's what we want to do.
Mm.
And actually there's some trend towards trying to make bioidentical hormones into birth control pills. Of course, this hasn't been completely lost on the big pharma companies either, that, to incorporate more bioidentical hormones. But that's not the mainstream products that are out there at this time. So basically, as long as I'm not trying to provide birth control with the hormones, and then there are other ways to provide birth control, then I can give bioidentical hormones and get all the benefits by giving the right hormones. And that's what we want. We want to restore all the optimal functions of the body throughout every organ system. And that requires the same hormones that the ovaries would naturally make, that in this case, they're not making optimally. It's similar. Think of someone who has type 1 diabetes, right? They can't make insulin. So initially, they had to use like insulin from a rabbit. That didn't work out too well. Then brilliant people figured out how to make human bioidentical insulin. It's
Mm.
completely transformed the lives of type 1 diabetics who can't make insulin from their pancreas. So if you are deficient in a hormone or insufficient in a hormone, to me, the optimal approach is give the exact hormone that you don't make enough of, or you don't have enough of. Don't give some mimic that is not ever found in a human naturally. Give the identical hormone to what is lacking, not some alternative, right? Like they had this experiment called ultra processed food, right? That hasn't really worked out too well. It turns out that real food from a real garden is way superior to factory made food, And the same thing with hormones. Just because they can make fake or faux hormones doesn't mean we should use them when we don't have to. So I just say use the real thing when you can. Eat
Makes
real
perfect
food
sense.
and have real human hormones.
Love that. Love that. Well, Felice, it makes perfect sense. I appreciate we're coming out of time. Um, I just have one quick fire question for you to end, if that's all good.
Sure.
Lovely. I always love asking health experts about their own health practices. And if in the last sort of, again, 5, 10 years, what one health practice have you taken up that's had the most impact?
Well, I would say it's working on stress. Unfortunately, right now, by the way, I have a little cold, which somebody may have noticed. I just got back from doing lectures on a cruise to Alaska. And I'll tell you, those cruise ships are incubators for infections. Like I came off with a cold, just what. But I would say for me, it's been dealing with stress. I mean, we live in a boiler, that can always, boil over, when we're in healthcare and we're dealing with sometimes life and death issues. So self-care is so important when it comes to stress. So I like to listen to soft music. I love this sort of like, it's not exactly spa music, but it's kind of similar. It's like, I just find it super, super relaxing. And I take almost every night a relaxing hot bath, and I just close my eyes and I have my soft music and I just do like my little meditation, and I'm relaxing and I feel really refreshed in like a calm way, and then I dump into bed and I fall right to sleep. No insomnia. It's very, very calming. So I would say it's doing self-care and dealing with stress. I mean, I can't even tell you how long it's been since I've eaten processed food. So it's been, I guess you can say that that's just standard of my life, is that if it came from a factory, basically I won't eat it. So I abandoned ultra processed food so long ago. But so to me, that's just what everyone should do. Nobody should eat processed food. How much more data do you need on the badness of that? But, even people who are like doing other things, like they'll exercise for an hour a day even, and they eat the right foods, but they're chronically in the pressure cooker. They're always under stress. They're not going to be optimally healthy. It just doesn't work that way. So I would say that working on mind body practices, working on stress, when the more you learn about stress and chronically elevated cortisol and what it does to your circadian rhythm, your gut microbiome, and everything in between. So stress is the biggest killer. It's so terrible. So I would say controlling stress has been probably the best thing I have done for myself.
Wonderful, wonderful. Well, yeah, I want to go and have a hot bath and add that into my routine. I think that's the sort of blind spot with health these days, is actually a stress mitigation approach. Dr. Felice Gersh, that was so fun, and I really can't thank you enough for coming on. I've learned so much, and I think it's a really valuable message you have. Um, you people must check out your YouTube channel and your books. I really enjoyed it surprised me a lot of the videos that you had on your YouTube channel, because you're much broader than I think this conversation will reflect. We spoke about one topic and one topic well, which was wonderful. But yeah, I would highly encourage listeners to look out for your YouTube channel. And where else can we find you?
Well, I'm actually in my office. I have an exam table right over there. I converted one of my exam rooms into my little video room. So for people that are in the US, or I mean, if you want to take a trip, I have a medical practice where I actually see people every single day. So I actually do the old-fashioned medical care. I see people in person. I can do telemedicine. I can actually do that to the UK. I can do telemedicine, but I can't prescribe in the UK. But and in addition, I have published quite a few articles. So if you go to like Google Scholar and you put in my name, you'll find a bunch of articles that you can read that are published in like the British Medical Journal and Mayo Clinic Proceedings. And you can actually read a lot of them are like review articles on all kinds of topics related to estrogen, my favorite hormone. And I hope to write more books coming out. One of the topics I'm really interested in pursuing right now is dealing with what I call the forgotten generation, the women 60 plus who were told when they were going through menopause, hormones are so dangerous, we're not going to put you on them, even though you want them, we're not going to give them to you. They're dangerous. And now that it's clear that they're not dangerous, I mean, those of us in the know knew they were never dangerous. They were positives, not negatives. But that's what was happening from the Women's Health Initiative. And now they're being told, well, we're good, but now you're too old. So you missed the boat, lady. Okay. First, you were told that they're too dangerous. Now you're told you're too old. So the question is, are they really too old? What can we do to facilitate women who are 10 or more years from the onset of menopause or over 60 to help them to reap the benefits of hormones? And I believe that we can. I think that there's a lot we can do to not just say, sorry, lady, it just didn't work out for you, and now, we'll just watch as you develop osteoporosis and cardiovascular disease and cancer and dementia. No, we can, I think we can help that group. So that's sort of my new passion project, is
Oh,
to
wonderful.
help that subset of women, the forgotten generation.
Wonderful. Look, thank you so much again. It was amazing. Really enjoyed it. And yeah, really appreciate your time.
My pleasure.